Who here knows about bridges to housing? Just to set some context. Oh, a few people. Okay, our job's done, so let's go home. We're good, right? Joe, do you want to come in? This year, I thought it would have been a good idea to invite a few more people to present this program along. So there's a couple people back there too who's going to talk about bridges to housing this afternoon from a different perspective. But Joe, our executive director, knows a lot about homelessness. That's been her entire career. And Radek and I are the clinicians on the team, so we do a lot of the assessments. We're going to bring that piece of the new data from bridges to housing, but also the clinical aspects of what we have to do for the screening and so on. So, Joe, you want to come and say a few words? That way I don't have to talk the entire time.
Hi, everybody. Just going to get settled here. It's an honor to be here, to be presenting with two of my colleagues on a few things, talking about working with people with developmental disability and people who are homeless. So again, it's wonderful to be here. It looks like I'm going to be getting a Twitter photo. So you'll have a chance at the end of each of us speaking to ask questions. We're very open to talking about any of the slides that we're going to be presenting today. As Sylvain mentioned, I'm Executive Director of the Intercity Family Health Team, and I've been there now for about 2 years. Previous to that, I worked at an agency called Toronto North Support Services, but altogether my career spans about 40 years, and I've managed and worked with a lot of programs with the homeless. So these are definitely my people, and it's an honor to be here to talk about our work with the homeless, and thank you all for coming. And I need my glasses. So first I'd like to just set some context. I think probably a lot of you know that we are really in a crisis right now in Toronto in terms of the number of homeless people and the lack of resources that we have. So on the slide you can see, sounds like a lot of number, 5,400 permanent shelter beds. Unique visitors, 16,000, but an incredibly low vacancy rate in Toronto. And you can see that our monthly average rent for bachelor, $942, but lo and behold, the shelter allowance is only $479. Probably not telling you something you don't already know for those of you who do try to house people in the community, which means that people will use their entire disability check if they're lucky enough to be on disability, and then there's no money left for food, there's no money left for other things, and it's incredibly hard, those of you who look for housing, to find housing for people. This statistic is chilling. 99,993 households waiting for social housing. And right now, for those that we'll be talking about today, those who have unique needs or complex needs, it's about a 7-year wait for supportive housing. So often the kind of housing you're looking for people are independent units. And for many of our folks that we work with, they need something a little bit more than an independent unit with somebody who has a large caseload and can't visit very often. So I wanted to also express that this winter, some of you might be reading in the paper, every time a respite facility was opened, it was full almost immediately. So we had an almost unlimited need for to pull more people out of the ravines, under the bridges, in stairwells. It's been quite a crisis this winter. So we actually don't know the actual number of how many homeless people there are in Toronto. So it has been harder and harder to house people. In terms of homelessness in Toronto, most people that go into a shelter actually exit the shelter system in a couple months. It could be lost their job, relationship breakup, all kinds of reasons why people would leave being housed, and also our, of course, terrible housing vacancy rate and the cost of housing. But there is an 8% group of folks who have been in the shelter system for a very long time. Our help team, I'll talk about that a little bit later, but we provide care for current and former Seton House men. I'll mention that a little bit later. But we have men that have lived in the shelter for decades at this point. And so this is the population that particularly pulls at my heartstrings, people who are stuck in the shelter system and they don't have the ability to live independently well without more supports. So we're really concerned about that 8% of the people who use 43% of the shelter capacity and aren't able to move out. The city has developed a really excellent plan. This is a strategic plan for the city of Toronto from 2014 to 2019. Housing Stability Service Plan is called. And I wanted to draw your attention to two key actions, and this really has enabled us to work in partnership with the city with some unique programs and projects we'll talk about. So one is that we need to have a service delivery model that addresses the complex needs for those who do stay in the shelter longer. So that's a really important point, and that's one of the key actions. The second one is to develop comprehensive strategies to ensure that we create housing that actually wraps around care with the needs of specific client groups. So that is one of the key points I wanted to make in our partnership with the city. You'll hear more about that. So all of you are here because you have expertise in the world of developmental disabilities. And as somebody who has worked in the area of homelessness for many years, in fact, I've worked probably over 40 years working with different populations of homeless people. But something some of you might not know about me is I'm also the parent of an autistic adult son. And so here I have an adult son with autism that I've cared for, and he continues to do pretty well. I never knew that there were so many people with a developmental disability in the shelter system. And I'm a mother of an autistic son. So one of the learnings that we'll tell you about is a huge learning about how many people that have an intellectual disability or a developmental disability that are in the shelter system. It's often unidentified. As somebody who, again, I worked mostly in the field of mental health and addiction issues in the shelter, many people who are in the shelter system who have from mild to more severe levels of developmental disability, in the shelter system, if you've ever worked in one or been connected to one, you know that it's often dangerous to show vulnerability. You need to look strong. You need to look like you understand what is going on around you, and also you want to make sure if you're not able to read, you don't want to identify yourself as somebody who can't read. You're trying to survive as best you can. So it often goes unidentified. People might be able to identify somebody with a more complex level of developmental disability, but it's missed when it's more mild. This group is often vulnerable to exploitation and violence, often have other complex health needs, and sometimes the interventions that work with one group might not work with a group of people, and you would know that better than I. You could probably be up here talking about strategies that work and that don't work for this population. But often in a shelter system, you're trying to keep people as safe as possible. And if somebody's behavior is bothering other people, there's service restrictions and there's other kinds of interventions that won't work with this group. So this is a group that often has difficulties navigating fragmented service systems, and staff in shelters often don't know too how to tweak their services for this group. just want to make sure I'm not going way over time. Okay, here we go. So some of you, how many of you know of Seton House? Wow, okay. Well, I don't have to say a lot about Seton House. I've worked as kind of a connection with Seton House for a lot of years. I was a frontline worker years ago and had clients who lived at Seton House. I was a manager of the one of the at-home projects. Some of you might have heard that project, trying to house people that other agencies hadn't been able to house. So I was there as a worker, as somebody who worked with people there, and now as the executive director of Inner City, I have more overlap with Seton House and able to get to know some of the fine work that goes on there. I love this subtext of Seton House, only 3 kinds of men, somebody's father, son, or brother, which I think is really important to keep in mind. People often just lump all the homeless as one category, and they're individuals with histories and life stories. There are several programs at Seton House. There's emergency shelter, we call it the hostel program, the O'Neill program that works with refugees. There's the long-term program on the 4th floor, and the annex infirmary program with a managed alcohol program. You might not know that Seton House started actually as a building on a street called Seton Street in Toronto. Started in 1931. It was the original building. It was torn down in 1958. So it opened at the beginning of the Depression years to reach a growing number of unemployable men, quote unquote. That was the term back then. It now houses around 600 men. The building where it's in now opened in 1959, and we're working on closing it and rebuilding. So it's hoped that at the end of 2019, Seton House will be closing, and in its place for the next few years in between will be about 5 or 6 transitional shelters with embedded health care, we're hoping, in each of those transitional. The new building will be amazing. These are some of the drawings below of what the new Seton House, it probably won't be called that. We've been calling this whole proposal the George Street revitalization. So it will have health care inside it as well, but it'll also have community hub programs, space that people can rent. It'll have both men and women in the programs, also trans individuals. So it will be, if all goes as according to plans, and of course, it all depends on funding, but we're hoping that it'll be quite beautiful. And now I get to tell you about the program that I'm so proud of and why we're here to give you a bit of an update. Some of you heard about Bridges to Housing, I believe, when Dr. Roy presented last time. For those of you who didn't, I'll give a quick overview of how we started, and then when Radek and Sylvain speak, they'll tell you a little bit more about our progress. So Bridges to Housing started as a demonstration project. It was funded for 2 years originally, funded by the Ministry of Community and Social Services Developmental Disability Housing Task Force, there's a mouthful for you, aimed at identifying 25 homeless men and women with developmental disabilities and then providing them with primary care, case management, and housing supports. So we'll tell you a little bit more later about the process of finding these individuals and what happened. But I wanted to recognize the partners that were part of Bridges to Housing and still are. We benefited greatly from this partnership. So there's the Developmental Services of Ontario and Community Living Toronto. Both of these agencies contributed so much in-kind support from the DSO, in-kind psychologists, a lot of data analysis from Community Living Toronto. You'll meet our APSW worker on the team, and also a lot of oversight and support from the City of Toronto, 2 amazing case managers, and also housing allowances from our team. The 2 psychologists that you'll meet soon. We'll have our rec therapist, a health promoter, who will also be speaking. Kristen, a nurse practitioner. We have social work, admin, IT support. Really, the whole team was part of the Bridges to Housing, and very proud to be part of it. And then St. Michael's Hospital in CAMH, we're also providing the research component of our team. So it was a quite robust team providing care as a research project and as a service project for 25 individuals. Tell you a little bit about our clinic, and this is where my part will wrap up. Very proud to be part of Inner City Family Health Team. We started in 2003 as a small medical clinic that opened inside Seton House. 7 years later, we became an official family health team and moved into a clinic across the street from St. Michael's. We still provide health care within Seton House, but as a family health team, we provide care not only to current but former Seton House men, so they can continue to access health care as long as they would like. Most of our patients or clients have complex physical, mental health issues. Some have lived at Seton House for a long time, others not. Many are in and out of hospitals, jails, they've slept rough outside, and many have a shortened lifespan. A lot of our folks that come to our clinic aren't successful in housing. They'll try over and over and go back to Seton House, and many are refused supportive housing or long-term care placement. So we're lucky to work with the fine staff at Seton House, our fine group of folks at the clinic. Many shelters are very jealous that we have this partnership at Seton House and would love this health care in their shelters. But I think it really is a case of all of us advocating for that, and would love to see that happen in other shelters as well. Just checking my time again. Oh, I'm almost out of time. So that's my part of the presentation. I wanted to set the stage, and so keep you on the edge of your seats as you hear more about what now is happening with Bridges to Housing and the next stage of the journey. Thank you.
I have a bad reputation. Apparently last year I was moving around the room too much, and it caused difficulties with a cameraman.
Not
and
too much.
You know what? I'm going to try to constrict myself to the stage without falling over. It was an incredible journey. I think since we started this whole thing back in 2013, 2014, if we look at even all the way back to 2012, when we started looking at some of these individuals coming in a shelter system with kind of neurological conditions affecting cognitive functioning. So here I'm including things like dementia, brain injury, developmental disabilities. When I started my work at Inner City Family Health Team, I actually did not anticipate finding anyone with a developmental disability in the shelter system. My assumption at the time was that the schools or hospital system would have caught them before they end up being homeless. And if they were homeless at the time, they had already been connected to developmental services. That realization was kind of shattered to some extent when we started actually working. And when I started doing some assessments, though people were being referred to me for dementia and brain injury, there's a subset of people that kept creeping up, individuals with developmental disabilities or neurodevelopmental disorders. So we started thinking, and somebody at the City of Toronto put a bug in our ear. Leslie O'Reilly, who was on the Developmental Disability Housing Task Force, made the connection. Said, hey, is there a project here for us to develop? Is there people in the shelter system with developmental disabilities? And I said, yeah, there is. So a group of people got together, made an application to NCSS for Bridges to Housing, And I believe we originally did not get the funding, but with a lot of insistence and support from a number of folks at government, the project was successfully funded, and it started the program basically, and it started like us in a way of thinking that, changed the way we considered how we do things in a shelter system. So that was a really good program. And between 2015 and 2017, that's when the pilot was running. And at first, we really thought about, just finding 25 people, but that was actually harder than it was to find these individuals, because for Bridges to Housing, we had to look for folks that were matching with the APSW service that could live independently in the community. Most of the people we were actually diagnosing in the system were way too complex and required 24-hour supports, which we could not provide. So we had to start thinking differently, and we went and actually did assessments in 9 shelters in that span of time to try to find people who actually meet the program. The end result is that we did find our 25 individuals, but we found so many other people in the shelter system now that were just stuck on wait lists. We didn't have the fund or resources to actually support them, or the housing to support them. And the good thing about this is that the Ministry of Community Social Service realized that they need to do more. We had, luckily for us, the Ombudsman working on this as well. And recently in the fall, we got expanded funding. So our Bridges to Housing has become an annualized program at MCSS. That's one good news. But the minister also gave us extra funding to do a little bit more. So she went and did her part and tried to get us a little bit more funding so we could actually do more. And we also, another good thing that happened is the Ministry of Health got involved as well and gave us another grant. What this means for Toronto and the rest of the province is that more people now are going to be in shelters across the province are going to get the opportunity to get connected to services. So the Ministry of Health Funds is going to send us to Kenora, Aurora, and Ottawa in addition to Toronto to kind of expand what we've started here in Toronto to see if there are people in shelter systems in other jurisdictions, and also start looking at what are the profiles of these individuals. Or is it the same? Are the gaps the same in different cities as it is in Toronto? Do we have a housing problem in other cities? My assumption is that yes, but we don't really know because there's no data. The other good thing happening now too is as a result of discussions with the Ministry of Health and MCSS, we're going to start monitoring through our triage process human trafficking. And we're also going to look at the opioid crisis and actually start asking hard questions at the intersection of homelessness and developmental disabilities. Is there more we need to do? Because this, human trafficking, and I know this morning you had a nice talk about this, that was not on my radar even 6 months ago until someone in our team was flagged as being part of that system as well. There's human trafficking happened right under our nose, and I wasn't even aware of that. And now the question is how many more vulnerable people in the shelter system actually are being trafficked with a developmental disability or otherwise, and we don't know right now. So we're going to start looking at that more closely. How many people die of overdoses in shelter system? How many people are hooked on opioids and other drugs that actually cause harm? And right now we don't really know that. So we're going to start exploring that as part of our triage process with Bridges to Housing. So these are all the good things that has resulted of this project. And if we go back just 3 years ago, most people would have not, I didn't make the connection, most people wouldn't have made the connection between developmental disabilities and homelessness, let alone human trafficking. And now it's happening. So the insight is there. People know that it's actually there, but now we have to do a little bit more to find out how bad it is. But then the next step will be, okay, what do we do about it? What do we do about the housing situation? What kind of housing situation do people need? So at least now we've got a little bit of funding to look at that more thoughtfully. And I'm monitoring my time as well, so Radek doesn't get shortchanged on his presentation. Little picture there. The DSO functions in a given way, right? So we have my colleagues at the DSO receive a referral to do a developmental disability assessment, so the psychologist gets sent in different directions to do this eligibility. What we had to learn a couple of years ago is that process is a very lengthy one. It can actually, we had some cases that it would take 2 to 5 years for the person to even get the psychological assessment is the first part to actually get into developmental disability or DSO. And because people were homeless, they were hard to pin down. So ultimately you set an appointment, they don't show up. And that was my case as well. 50% of the people that we had booked for an assessment in our service weren't showing up. And we quickly realized, well, the disability, the issue with homelessness, chaotic lifestyles, a number of reasons why people don't show up. And with the DSO, it was the same thing. So 5 years, imagine just to get your psychological assessment. So you're living in a shelter system, bouncing from shelter to shelter. You might be in one shelter 1 week, in another shelter in the following week, and we lose you in the system. So it was kind of a perfect storm for us, ultimately, in a bad way. So they have no family, no supports. They have severe disability, severe poverty. There's the issue of the cloak of competence that seems to crop up more often than not. We had minimal access to health records as well in these individuals, so it's hard to really understand the pre-18 condition component. People weren't showing up, they disappeared in the shelter system. These are all real life challenges for health clinics like us. We tend to be in our ivory towers. I work at CAMH, right? I work in a clinic and I wait for patients to come in to see us for an assessment, and oftentimes people can't make it. And on top of that, if they're homeless, you have bigger priorities than showing up to psychological assessment, right? So you have to find food that morning. You might not have a TTC token to actually get to the appointment, and you might not be lucky enough to have a case manager to accompany from point A to point B if you have a severe deficit disability. So we started thinking differently. What if, first up, the first basic component is we have to get in there, in the shelters, to actually do the psychological assessments. We have to meet them where they are. But another part of this is really ruling out people that shouldn't be in your clinic in the first place. So many people referred to us should not be seeing us. They should have seen perhaps a psychiatrist or another clinician. But when they are in a clinic, we still have to do the assessment, try to answer the question, and that kind of slows us down considerably. So working with an epidemiologist, we threw that around. We said, okay, that's not a system that works. Let's now throw that in the garbage and rethink our approach. And this is where our triage, or what we call the RARs, or Rapid Assessment and Residential Support, came in. So now we're looking at entire populations. We did this at CAMH, we did this in 9 shelters. We go in a place and we spent 2 minutes for every single client in that agency. And then we ask critical questions about housing, about function, about behaviors, about cognition, but also about things like developmental disability, ABI, and dementia. The frontline teams know these clients. We wanted to download their knowledge in 2 minutes to really guide our triage approach. So imagine Monday morning, in this case Radek goes into a shelter, we do the triage, we go through, if there's 200 people in that shelter, we basically assess everybody. The next day, we develop another procedure, so we're in there the next day in a shelter, we do a psychological screening. We know right there if the person has an ABI, dementia, or developmental disability. We can, not enough to diagnose, but enough to really focus our energies a little bit more effectively. And with DSO support, so the DSOTR, basically Toronto region, was with us in the shelters as well. So by Friday, in the best case scenario, we had somebody in the DSO within 5 days. So imagine going from 2 to 5 years, 2 weeks on average, down to 5 days in our best case scenario if we align everything and remove all the red tape for people to access DSO. Now that's just the front part, right? And now all of you know that once you're in the DSO, there's a lot more that needs to be done in terms of housing and support and so on. But for a homeless person to get connected to passport services, passport funding, needs a guaranteed TTC pass. Just that alone means quite a bit, right? We guarantee ODSP because of the DSO agreements now with ODSP. So if you have a developmental disability, you should not be on OW. So all these little things are coming into play now, and now we need to do a lot more as well. So what's needed to make an impact? I think that's something we've learned the past couple of years. People shouldn't have to wait for a psychological assessment. There has to be a rapid turnover. So once you're connected to DSO, there's another assessment called the SIS or ADSS that most of you probably know. That can take quite a while to get access to as well. So you can be in DSO, but you're kind of in nowhere to, basically you don't know where you're going to land in terms of services and support. So all these kind of things now need to be done automatically, and we're trying to do that within a couple of weeks in a shelter system, just to speed things up. And in terms of passport, we've managed to have a few clients in our list who've got passport services within 3 months. So they didn't have to wait. So ultimately, because of their homelessness and their basically many of our clients are they're at the brink of death, we managed to be able to prioritize them in a shelter system, and we have good collaboration with DSO and NCSS to make sure that these individuals get connected to as many supports and services as they can. I'm going to go a lot more quicker now with the next part. 6,000 homeless people in Toronto in the shelter system. That's the latest stats. That's a lot of people. When we did the Bridges to Housing triage, we assessed about 1,200 people as part of the triage. That's a good chunk of people. We realized that 27% of folks in the shelter system were suspected of having a developmental disability. That's a pretty big chunk of people. And obviously this is not a diagnosis, but it's people being flagged as something, an incident that happened in childhood, either brain injuries in childhood, genetic disorder, something that's developmental in nature, severe neglect that can affect neurological functioning and development. We also have the adaptive functioning issue. So people have difficulty reading, writing, and so many basic ADLs, for example, could be challenging. And there's a cognitive impairment. So frontline teams know these things. And when we flag these things, 27% ended up being flagged as a potential developmental disability. A lot more people than we thought. So if we run down, basically now we're doing this with DSO, how many people do we actually need to connect, how many assessors do we need from DSO, how many psychologists, and we're doing the math now. If we wanted to get all these people every year connected to DSO, it would require several psychologists, basically, and assessors from DSO just to get people connected. And luckily we've got funding to get cracking on that. We don't have what I wish we had, but we definitely have enough to start. Another finding that we've had is that, and I'm going to make you work back there.
Okay.
We've developed 5 levels of housing support that to us is helping steer the conversation about housing. Level 1 is really folks in the shelter system that are there because of poverty. There's no mental health overlay, there's no real functional issues. Almost 20% of those experiencing homelessness, according to our surveys and our work, basically are there because of poverty reason. Level 2 is what we do pretty well in Canada, which is about case management. Individuals with mental health concerns and so on that could still live independently with supports. 46%, almost 50%. So if you combine level 1 and level 2, that's the majority of folks who are homeless. The level 3, 4, and 5 is something that we haven't looked at more very effectively before. Is individuals who need 24-hour support, some kind of support. So it could be a home, a nurse, long-term care, for example. Level 3 we label as people needing 24-hour supports, but not necessarily clinical support, not necessarily a nurse or behavioral therapist and so on to provide care, but rather a presence to make sure that they eat, to make sure that they don't hurt themselves, to make sure that there's somebody there if they have this, perhaps a seizure disorder just needs to be monitored, or diabetes, or some mental health concern. But level 3, almost 20%. Level 4 and 5 is really what we consider like almost 17% combined. Would be more the long-term care equivalent. 24-hour clinical supports, 7 days a week basically, where the individuals are severely compromised because of medical or behavioral challenges of some sort, and cognitive challenges. Level 4 is really what long-term care is there for, right? Individuals who might be aging, might have dementia, and coming around the corner. Level 5 is really a service that doesn't exist in the community. Imagine somebody with a developmental disability who also requires a managed alcohol program. So we need to prescribe alcohol. What we've realized is that when we look at long-term care, and a lot of housing providers, they do not want individuals with comorbidities such as, if they're crack users or alcohol user, or they smoke and so on, and they have cognitive challenges, then they end up stuck somewhere on a wait list. And that's why we have, there's somebody diagnosed at CAMH who had been at CAMH for 20 years. Somebody we've seen at Seton House had been at Seton House for 27 years. So there's a lot of folks either in jails, hospitals, or shelters that have nowhere to go. And this is the level 5, a minority, but still 8% is a pretty significant number that we can't forget. So dementia, we're seeing 13% rate right now. ABI that are known to the caseworker, like something severe enough, 34%. People with adaptive functioning impairments, or ADL, 78% of the population are homeless, have some sort of adaptive functioning challenge. Behavioral challenges are very moderate to severe. 36% of the population have severe behavioral challenges of some sort. And we have some cases where it could be a severe case where they stab somebody once a year, or they do something very dangerous of the sort, or it could be milder but repetitive behaviors like aggression and assault and pushing and stuff like that. So when we look at moderate to severe, it's really, they stand out because first of all, you're in the shelter system, they're already challenging there, but 36% is a big challenge. Addiction is big, 66% had alcohol use. That's really hard to house somebody when they use alcohol or other drugs. When you look at multiple substances together, basically about a third of the population, 33%, used multiple substances, and 22% required a managed alcohol program, so where we prescribe alcohol on a daily basis to prevent things like seizure disorders. Lots of housing failures for persons with intellectual disabilities. So when we look at the percentage here, 25% had no known housing failure. What this means here is that we haven't really tried to house them yet, but ultimately, and then 63% actually had one housing failure. So somebody's tried to house them somewhere, but they end up back in the shelter system. And then as we start looking at 2 or 3 or more housing failures, we start to realize there's a problem there. And Radek, you can start getting up and start booting me off the stage here. When we look at the comorbidities of folks with intellectual disabilities, the actual people we had diagnosed, many had a history of incarceration. So we need to be in corrections facilities, screening more effectively and diverting them from homeless shelters. So 36% of the males that we've seen had a correction. They were in jail before coming to the shelter. Abuse in childhood, ABI overlaid with developmental disabilities, dementia overlaid with developmental disabilities, mental health concern here, 94% of males, 93% of females had a mental health overlay with a developmental disability, people we've seen. So that's a big chunk. So they're all dual diagnosis. History of drug use, very high. Current drug use, lower, but high as well. And so that wraps up my piece, and I'm hoping that we'll have a few minutes for questions at the end, but ultimately we've uncovered something big. We have a lot more work to do.
Okay, I'm not going to make the cameraman move around a lot, so I will stay in place. So anyways, thank you everyone for having us. It's an honor to be speaking to this crowd because I know all of you do a lot of the work ahead of time for us. Today, what I'm going to be talking about is sort of the screening process. So everybody sort of has an idea of what we're actually doing through this. And I know Dr. Roy did the MOCA with the group last year. This is sort of similar to that. We're not going to actually be doing any interactive screening today, but I'll explain the procedure. But before we do that, I just want to sort of introduce you to some of the achievements that we've managed to do over the last couple of years. Again, improved access to DSO. Instead of 2 years, we've in some cases narrowed it down to 3 weeks. Quick access to ODSP, so now when somebody gets through to DSO in parallel, they get ODSP granted to them. Access to passport funding. Oftentimes it comes with a $400 allowance. Case management supports as well as primary care at our family health team. We've managed to save lives. One of the people I'm going to be talking about actually was, he would have died if he wasn't in our care. We have better coordination supports, increased awareness of the population and their functional needs. We've been involved in conversations with different sectors. As you can see here, we made many informal connections, and it's been really amazing to see all the community agencies coming out and basically offering their support for the project and this initiative. And obviously, there's a lot of work that remains, but we're hoping that hopefully we'll do some of that in the next year or two with the new funding. So Peter, as we're calling him here, he's one of the examples of somebody who actually did match for our program. I'm not going to get into it too deeply, but again, this is sort of like a standard profile that we encounter. Came from a pretty broken home, alcoholism, physical abuse. Oftentimes what we see, I'm sure all of you are familiar with this, people taking advantage of vulnerable people. So this happened with Peter. He was his inheritance was taken from him by his sisters. He came to Seton House in 2002. He's part of the managed alcohol program. So he also suffers from alcoholism. 11 head injuries since 2005. Quite significant for a variety of reasons. He's been involved in the legal system, probably because of disinhibition related to brain injuries. We managed to house him independently in the private market. Still though, lots of difficulties there. Eating a frozen pizza without warming it up and getting food poisoning from that. Just some examples. And again, finding half consumed bottles of rubbing alcohol in his apartment. These are the kinds of things that we're dealing with. Despite all these difficulties, we've managed to maintain the housing and keep him going to his court dates and appointments. Larry is an individual that was accepted into the B2H program. However, it turns out that his needs are quite significant, as Glenn will tell you. He spends a lot of time working with this individual. Multiple comorbidities here. You see from an early age, hydrocephalus, spina bifida, poor medication compliance due to memory, all sorts of medical issues. This person almost died if it weren't for our nurse practitioner at the family health team. Again, victimized by individuals on the street and in the shelter. But now he's connected to CCAC, PSW services, all sorts of things through our program. And finally, this is an individual, John, who is actually still at Seton House because his needs are far too complex, and there's nothing that exists in the community to support an individual like this, mainly because of behavioral issues and being involved with the law multiple times, and they can't support this person in the community on a managed alcohol program. So, and again, his needs are quite severe. You can engage with this individual, leave the room for 2 minutes, come back, he won't even remember that you've interacted. So unfortunately, we're working on getting this person housing, but as it stands right now, he's still at Seton House. So really quickly, our neuropsychology service typically involves screening and comprehensive testing at the family health team. The thing there is typically comprehensive testing can take about 8 hours to do. Now, I don't know your experiences with the homeless, but this is very difficult to pull off in the population. So actually us developing the screening tool that I'm going to introduce to you has been really helpful because essentially we've cut down 8 hours down to about 40 minutes. But the actual testing itself may take 20 minutes. So the other 20 minutes of it is clinical interview. And again, we look at several cognitive domains: memory, executive functioning, language, attention, visual spatial abilities. We look at adaptive functioning abilities. As Sylvain mentioned, it's quite compromised in homeless people in general. And we provide support for a number of people. So, really quickly, our neuropsychological screening looks at global cognitive abilities. So all those abilities that you saw earlier, we look at that very quickly just to give us an overall sense of what the person, how they're doing. Premorbid functioning, I'll talk about this in a sec. We look at the risk of mental health issues. Again, we do a clinical interview to see things from the person's perspective, and always we complement this with a chart review. Oftentimes, people aren't very good at self-report. Sometimes they don't have insight. So a chart review, if it exists, is really helpful in confirming a person's own self-report. Now, as Sylvain mentioned, we engage in the RARs. That's a really great way of narrowing things down really quickly for every client. Again, it takes 1 to 2 minutes per person. And from that, we can determine if a person has a strong likelihood of dementia and acquired brain injury, developmental disability, or mental health issues. Again, we rely on frontline staff to give us this information. Without them, we'd be nowhere. And again, it's important to note that these groups don't stand alone. Like, I mean, maybe if you've been raised in an upper middle class family where you never encountered a brain injury, or you're very good at adapting to mental health issues, you may see one single solitary issue. Oftentimes in the shelter system, we see people presenting with multiple comorbidities, including physical health issues, as you saw earlier. Now, one of the things that might be helpful for all of you in identifying these kinds of things without even really any clinical training is looking at the course of things. So again, all of you are very familiar with developmental disabilities. This comes about early in life, before the age of 18, and as a result of that, a person has a number of cognitive difficulties, and oftentimes they encounter difficulties with adaptive functioning, so communication, finding jobs or maintaining jobs, self-direction, navigating the community. These are some things that can be difficult for these people. And then in terms of an acquired, and it stays pretty stable throughout life, unless of course there's another insult that comes along. An acquired brain injury, you see a person at a level of fairly, I guess, competent functioning. Cognitive abilities are fairly good, and then they encounter neurological insult, so a head injury, a hit to the head, a stroke. And then what you see is a drop in cognitive abilities. There can be some recovery of function in the year following, and then at that point though, it stays stable. And finally, what you see with dementia is you see a certain level of functioning throughout life, and then later in life, usually after the age of 60, generally 65, you see a decline in cognitive abilities, usually in the area of memory, also executive functioning, and the person continues to decline until they pass away. Now, the way that we look at cognitive functioning with our screener is we do what's called the brief cognitive status exam. Essentially, it looks at different areas of cognition, so orientation. Everyone knows that, right? What's the date? Where are you? What time is it? Confrontation naming. We'll show people pictures and we ask them to identify them. People with brain injury can oftentimes not identify objects. So that's a good screener for that. Mental control, we ask people to count backwards or say the days of the week backwards. Spatial abilities, this is sort of a classic one. We see this in the MOCA, as all of you should be familiar with from last year. Drawing of a clock. That can be used very, in a lot of cases, you can see dementia very clearly when a person has issues with their clock, or brain injury can be identified in that way. Incidental recall is just a person's ability to remember things after a short amount of time. Inhibition is the ability to stop yourself from doing something that's well learned. So we do that by showing a person shapes, 2 different shapes, and asking them to name the opposite shape. And then finally, verbal production is just asking the person to name as many words that start with the letter F. Again, all these give us insight into a person's cognition in different ways. We also look at premorbid functioning. So this is done by looking at a person's reading abilities. It's quite amazing. Reading abilities, despite mental illness or brain injury or a multitude of different neurological insults, actually withstands that. So that's actually maintained from quite a young age into adulthood. So if we don't have a good history on a person in terms of their education or whatnot, we can estimate intelligence by simply having them read a word list. And from that we can get sort of an estimate of their level of reading in terms of grade and a standard score. And again, we use this tool called the RAT for reading subtests.
W-R-A-T, not
Yeah.
just the rat. Yeah.
not a sewer rat. And we also look at the person's clinical risk for mental health issues. So we use what's called the personality assessment screener, 22 questions. It takes about 5 minutes to do. The person requires a grade 4 reading level, so oftentimes our individuals with developmental disability can't do this test, unfortunately, so we get an idea of mental health issues by the clinical interview. And then again, finally, we interview our clients to get a sense of things from their perspective. Again, oftentimes we ask them about education. So one of the things that everybody should look for is if a person has had any special education in their history or a number of grade failures or difficulty in school. Sometimes people won't identify themselves as having a developmental disability. Instead, they'll say, I had a learning disability. All these things should be red flags. Everybody could do this on your own, though. You can sort of give a person a newspaper and ask them to do some reading. And from that, you can get a quick estimate of their abilities. And again, that correlates quite strongly with intelligence in many ways. So that can give you a quick idea. Again, employment, we look at that. People with intellectual disabilities have trouble engaging in complex types of work. And we look at psychological and psychiatric histories, medical, all these kinds of things to make a proper, quick idea of where the person is clinically. And finally, why do we do all this? Well, obviously we want to connect people to services, but also we can use a person's neuropsychological profile to help them better adapt to their environment. So one method that's being used, it was originally developed for individuals with schizophrenia, is called cognitive adaptation training. Essentially what we do is, with all that testing, we find out what are a person's strengths, what are their weaknesses or difficulties, and then we draw on the person's strengths to help them better navigate their environment. So let's just say a person's fairly poor with their memory. What we do is we put signs everywhere that give them reminders of important things, a big calendar so they can be oriented to what date it is. And as you can, we also do checklists for ADLs, schedules. Some people, if they're disorganized, you help them with pill containers. So it's been found, again, originally this was developed for schizophrenia, but there's a case study that found that this also works for people with mild intellectual disabilities, and it leads to increased independence and fewer symptoms of mental illness. So that's about it for my part of the talk. Again, thank you everyone for listening, and if you have any questions, we'd be more than happy to answer them.
It takes time to edit. Any questions? Yes?
I'm just wondering, if when you
about some of the screenings and stuff you guys have done with the shelters. Has there been already, or is anyone looking at some of the youth shelters that are leading in like the transition, but some of the other youth at risk programs where some preventative steps might also be able to be connected to the two, so to avoid longer term shelter usage or dependency by trying to find some things earlier?
As part of Bridges to Housing, we've looked at individuals at the two shelters, were youth shelters, and in hopes of doing more with them. So we did the YMCA and what's the Turning Point. So we started there, but ultimately it was kind of a stretch to kind of do that. But we did help individuals who were like 17, 18, 19 connect to DSO and start, the conversation about preventing chronic homelessness, because we know if we don't intervene at that age, things go downhill very, very quickly. The good thing about the new funding coming in with Connecting the Dots, there are no age limits and no basically we're going to be looking probably starting at the age of 16 to 99, basically in terms of like connecting folks in different geographic regions. We will go where homelessness is. So if there happens to be a youth who's homeless, Toronto will be more complex because it's wide, it's big, there's a lot of homeless shelters and so on. But we are having that conversation with collaborators and colleagues.
I just want to add a comment. Many of you know that youth in shelters have had a rough road. We think the predominance of developmental disability in the youth shelters, transitional shelters, is even higher. These are often young people who were Crown wards, who ended up in youth shelters, and one of our heartaches in the adult shelter system is, these are folks that will slide right into the adult shelters. So I just want to honor your comment, and we're hoping that this little project, which has already gotten so much attention thanks to our great staff and our clients and all, that this will start a real system change to look at really transforming the system and catching these young people before they end up going into youth shelters and going on into the adult shelter system.
Thank you for that. Also, I wondered if
after Deanna startles me, my voice is usually loud enough. I was just thinking when you were talking about the Crown wards, that is actually when you said Turning Point, that's who I was thinking of. And I was thinking about those that, have been promised, at 18 I can leave being a Crown ward and I can go live by myself. And I know, being from the DSO, I know many who have said, all right, I'm out of here, and then don't get the extended care. I'm not in children and youth, so please excuse me, because they may leave and they may do okay for a little bit, even a little bit longer than you would think. I wonder, with some of the changes that they're looking for the age within the different Crown wards, and even some other youth that are kind of entering transition age, and so they're not actually identified as Crown wards, if there's a partnership that could exist with the Children's Age Societies, because they are required to provide these psychological assessments, and I know they are supposed to be easy and they're not covered. I am a big follower of that. But I'm just curious, is that a partnership? I know with your being very engaged on multiple levels, Dr. Sylvain, that you look at those things and you advocate for free psychological care, but I'm just wondering, is there a push there? Is there somewhere we can say, it is time for all of those children's aids people to get those assessments?
Actually, it's timely that you said that. We made with our Ottawa colleagues, we made a proposal that each Children's Aid Society would have one psychologist on site to make sure that these people get the assessment on site before they transition anywhere. That proposal is being reviewed by the Government of Ontario, especially MCYS in particular. We have a meeting in 18 days or 2 weeks about that. So the conversation is being had. The question obviously is about budget and funding. And I know with the new budget coming out now, I've heard that's going to be very good for DS and mental health in general. My hope is that for people who actually need it, should be covered. But that's it, the conversation happening. We don't know. We'll know in 2 weeks whether that's going forward or not.
Thank you.
You guys are so quiet.
I know.
Oh, there's one question.
Here, wait, microphone. People on the stage probably don't need my voice elevated, but working in the female sector, or the women's sector, I think it's wonderful what you guys have done at Seton House and what you're doing with us at Women's Res, which has kind of jumped on that. But now, within the developmental services area, I've gone from, with almost 30 years experience, like Joe, all in the shelter with Toronto. Maybe seeing one a year. I have 5 on my caseload right now and 3 more that we suspect, and there's nowhere to go. Like, even if I do have passport funding, it's useless because they don't have the money up front. Nothing to do with you or the DSO, it's the way the funding is happening. Like, I think it's wonderful that we're creating all these supports, and I certainly don't want this in any way to seem like I'm not thrilled. But as you guys, all 3 of you know, we've had conversations just in the last 2 or 3 weeks about specific clients that are too complex for you. What happens? Like I'm gonna watch these women die in a park, is essentially what I'm gonna do. And I've buried enough this year,
I so share that pain. With something that we didn't talk a lot about up here, and possibly Dr. Roy and Dr. Budin will also jump in. We're part of a couple discussions about this, and one I'm really excited about is a proposal we've been working on for a while with Community Living Toronto and also St. Stephen's Community House, who have expertise in addiction. And we'd be looking at high support developmental disability housing. They have some housing that's coming available in about a year and a half and 2 years, be 24 units, I think. We're really excited about this because one of those, it would be both men and women. It would be at least one of the houses would be managed alcohol. We have a harm reduction focus, which is a real barrier for many people with a developmental disability to try to get housing with supports. We're really excited about this proposal. There was a bit of a delay in getting the housing, so that's maybe another year and a half. And then there's another one that we were just talking about in the car coming up, the Supportive Housing Coalition, led by some of the great agencies, Madison, CODA, and Habitat, looking at housing, again, higher level, not probably the highest level that we need. But right now, many of you know that even with a long, long wait for supportive housing, the supportive housing you get is kind of low level, really. Might be a worker on a hallway or an office on the ground floor. And for many of the people that you all work with, you need a lot more support than that. So I'm very excited about some partnerships that have been bubbling up. Right now, these 2 are on the go, but there's others that are being buzzed about. So we'll see what happens. So much depends on the will of the government and who's ever in power to put the funding that we need for not only really good housing, but really good supports. We need both.
Passport funding, interesting one, isn't it? I think we're having a lot of conversation also with Family Service Toronto and how to change the way that is administered for somebody who's homeless as well. So there's a few things you can buy with that, like a TTC pass, but that's one part.
Money up front, right?
Not for TTC. There's a few things that it can pay outright before, so we can talk about that as well. But that's scratching the surface, right? I think the housing is the burning issue for everybody.
I agree, Dr. Roy, absolutely, that housing is an issue, but almost bigger than that is the issue of supports, right? At our shelter, we're probably one of the highest staffed, right? I'm one person with a caseload of almost 40. 5 of them are at the extreme level. I know you guys know who I'm talking about. But the frustration is there's wonderful programs, like there's the clubhouse, there's the Meta Center, that these women or men would absolutely thrive at. And it would make a huge difference in the bigger picture, right? In terms of they have something to do.
during the day. They're not bored, which is a big part of why they're getting into these risky behaviors. They're not being taken advantage of in the same way because they're not sitting in the park or in front of the shelter. So, but there's no one to take them, right? So, yes, I agree that getting a TTC pass is great, but of my 5, not one of them could travel to those programs on their own. And I don't have a staff, unless I'm between the months of October and May, when I have a student, and that's it, right?
And that's a good thing. I think with Bridges to Housing, that conversation is being had at MCSS right now. So through 2 years ago, MCSS did not think they had any role to play in homelessness. Now we're saying that 1 in 4, 1 in 5 is their responsibility. The question of still support workers. So we have APSW in the room, so Glenn can talk about that role. But then there's, for clients who need, a more one-on-one support, there's that, and Glenn, you can talk about APSW service and what you tend to provide, but then sadly you need access to a little bit more as well. And MCSS was receptive at funding more SIL level positions to support people who are homeless. Again, this is dependent on funding. At least now we can have the conversation, but now we need for them to deliver. Well, we need to have that conversation before the election.
Yeah.
Because ultimately, I don't like to bring politics into this, but ultimately, let's figure out, let's look at all the political platforms and see who are going to support the development sector more effectively and homeless sector more effectively. So, one more question? Politics, eh? All right, let's do it, guys.
Well, I'm just going to say, as someone from the DSO, if you're going to introduce the idea of supported independent living, it has to be definitely in a different type of model than that's currently offered, and that time can't be restrictive to when people are available to you. It has to be when you need them. And so there's been some really interesting thing happen through community living with the recent multi-year residential planning. But I think what's really interesting, if you continue to make that request, definitely ask for still hours that aren't attached to any specific thing.
He's the expert.
Oh, no, I know.
We all know him.
Yeah, I mean, just a little support. I mean, even with us, and right now I'm attached to this Bridges to Housing team, which gives me this incredible added support. Usually I'm out there just on my own trying to deal with all the challenges that my caseload of 25 to 30 people have on their own, as do all the other APSWs out there. Now I have this team, it's amazing, right? We work in collaboration, we put our heads together, it's healthcare is about a phone call away. I think of a gentleman even about a week and a half ago, need to see a psychiatrist. Try to get a psychiatrist in the community, it's flipping impossible. I called Inner City Family Health Team. We had the person in on Tuesday, and now that person's on the road. The journey's begun for that person, moving up, positive. It's amazing. With regards to the passport funding and the challenges around that's huge, and we're running into that right now too, right? We have a couple of people who got the passport funding early, and also we're very fortunate, or the people we support are very fortunate that they were fast-tracked into that. I mean, their CIS scores, I guess, were quite high, being homeless, so that put them up high on that list. I mean, they didn't get a whole ton of money like a lot of other people did in the past, but they got something. So a couple of people were able to get the support through agency, right? Now, with so many people getting passport funding granted, the agencies are at capacity and they're no longer able to take on new people. Right? So the challenge we're having now, I was going to talk about that, but I'll forget anyway, so I'll say it now. We're pretty good at helping people with those core services, those important core services that they need, right? Housing, medical, psychiatric, doctors, thank you, Rose. Yeah, yeah, that's good.
I'm being honest, Glenn.
Nicely done, thank you for that. Yeah, but really the challenge we have is in that, what I call that outer circle, that stuff, all those enriching areas of a person's life, that really is how we identify ourselves, right? Friends, family relationship, hobbies, job, that's what you're talking about. People are just stuck. Okay, they got a doctor, they got 3 meals a day and a bed to sleep in, but their life is empty otherwise, right? They got no friends. These are people also with no natural supports either, so they have no family, no one else to assist them with that, right? Just paid staff who are there, right? We care, but we don't love them, because I also know that I'm dealing with a very skewed part of a population also. There's 10 times as many people, if you say, operating at that functioning level, or whatever that politically correct term would be for that, who have families who love them and care for them. So you got a family with a caseload of 1, where we have caseloads of 25 to 30, and we're just scrambling just for the necessities to keep them safe and keep them housed, and with the dream of helping them to achieve that full, wonderful life, but just having the resources there to do it is a great challenge. So I don't know. I didn't answer it, but I'm better at identifying problems than having answers. but we're trying. And yeah, I mean, what a blessing to have a guy like this and Radek and Joe.
So Glenn and I shared that thing about finding problems and no solutions. But no, it's something that at least we're having the conversations now. But I think from Women's Res, it'd be interesting to hear the feedback. What would be useful, and then we can table that and bring it back to MCSS at the highest level, and kind of say, let's make that happen somehow.
Yeah.
Good.
Thank you very much for the presentation and making a conscious choice to remain hopeful despite all the challenges that we are all still facing with the people we support. I work at Family Service Toronto, and I wanted to just say a word about passport funding. I'm not a passport coordinator, but I think 2 things are important to keep in mind. One, that there is some flexibility in some situations. You just need to ask for it. And B, that the flexibility that Family Service Toronto is able to provide is completely tied to the ministry's regulations. And so that's where the advocacy needs to be done. And absolutely, that is the piece about meaningful community participation has to come back to MCSS for all of us, from all of us, and from families and from people themselves, because there's even in the way it's set up, and we all know that there's a respite portion that makes the passport funding bigger for people. But if you're a person who is defined as an APSW, or a person who lives or can live independently in the community with some support, that portion is not available to you. So that, again, that's an advocacy piece with the ministry. So, and it's not just a question of getting people to day programs. In my very humble opinion, maybe some of you share it, the traditional model of day program activity is not appropriate for many, many people, especially I think the people you are referring to today. And so we need more individualized day programming. At least one agency who does this in the city, Montage, and we need more of that. And again, that is something that can be purchased with passport funding and created with a transfer payment agency. So yeah, there's ways, and we really need your advocacy at the highest levels.
Your colleagues have actually been very helpful with that at Passport. So we've been engaging your team for the past year now. And before Minister Jackson decided to move to health for some reason, we were having those conversations with her at the political level, but also at the deputy minister level. So I mean, they've heard our concerns, especially from the homelessness perspective, to make sure that these funds that are available should be flexible, they should be barrier-free, it should be easily administered, and the reimbursement model was not working as effectively as it could. We did have one client that we assessed who has now seen Lady Gaga because of passport funding. So for that person, that changed her entire outlook on life. She went from being very depressed to feeling hopeful about certain things. So it's not for Lady Gaga, it's not for everybody, but ultimately if we can start unlocking the benefits of what the fund should be used for, which is social inclusion and so on, we could do a lot more, definitely. I think we're running out of time, right?
Oh, we got 15 minutes if you still want to talk.
Oh, well, okay, questions? Hey, I'm happy.
Just one of my worries about PSW, about SILs, about passport funding, is all of them assume a certain amount of independence of clients, their ability to manage their own care, make their own decisions. And we've been finding more and more that clients who end up in SILs, I mean, I think I can name 3 of them who've ended up in hospital with toes being amputated because they have diabetes and they don't know how to take care of themselves. So while the model is maybe respectful, if you have no idea how to manage your own care, make your own decisions, and you end up in a SIL, well, you're going to fall between the cracks and you're going to end up on the streets again, or you'll end up in the hospital again. And passport funding for parents who are intelligent and connected and everything, they have no idea what services are out there, and it's assuming parents know how to be really good case managers. So there's goodwill in those things, but I worry about the clients who haven't got the capacity to make those decisions themselves.
You want to crack at that one, since your clients you've discussed? I'll put you guys on the spot. Not too much, right?
Very good point, and I think that's why we need a lot more supportive housing options. You know, we for years, I think I mentioned in my talk, with the At Home project, there were 3 teams in Toronto, one from across boundaries, one from Toronto North, and one from Coda. We each took 100 clients each that folks had not been able to successfully house before. 70% of those folks remained in their first housing really successfully because they either had an ACT team or a case management team that were visiting them more often than most case management teams could. But 30%, guess what, were not successful. Even with lots of support, they just kept going back into shelters. We were pulling our hair out, we didn't know what to do. And so the team started using really dilapidated boarding homes as the only option that we could get people in quickly, and it was not enough support. We had a lot of disasters that you're describing, especially people who needed managed alcohol, who had really chaotic polysubstance use, particularly people with developmental disability who were given instructions to do things, saying, okay, I understand, like diabetes care, and could not manage that care at all. So I really think we're in a crisis of needing, if we're really going to end homelessness, we really need to help stabilize people within shelters, and we need supportive housing in the community of all sorts, so that people will have choice in what kind of supports that they need. But I absolutely agree with you. I think the days are done when we can just put people into a house and an apartment, even if it's subsidized, and expect that they're going to be successful, because we're all different. We all need different amounts of support. So I know some people who lost toes, and one gentleman a foot, and it was all just because they didn't understand. Yeah, so I hear you.
And we're hoping that some of the work that we do, where we build up this neuropsychological profile, can help aid in these kinds of things. Of course, you can't, let's just say you have a brain injury or a certain level of cognitive functioning. You cannot improve that. It's sort of where it's at. But as I mentioned in our presentation, having that cognitive adaptation training is one solution to that. Again, you adapt it it's individualized, it's based on that person's specific profile. So again, if they have problems with, preparing a needle, then you arrange an environment, or you teach them in a errorless learning kind of way, so that they can actually acquire those skills. Or if you're aware that they can't do that, then you ensure that they have the supports for that purpose. But again, like we've been talking about here, I think the system is sort of thinly stretched in terms of that. But again, we're trying our best.
Need a magic wand.
Advocacy.
Advocacy, yeah. I think I'm stressing out a lot of people with advocacy lately. Any other questions? Should I, go to each table and start stressing you guys out for anything? Yeah? If not, I think you guys are probably needing a break and coffee and donuts and whatever at this point, right? Yeah, they're ready. All right. You've been a great crowd. Thank you.